Hi, this is Brian Kim, and I'd like to share with you a case of aqueous misdirection and how I managed it. This is a new patient, a 75-year-old Caucasian gentleman complaining of blurry vision. He comes in with pressures in the 40s in both eyes, and gonioscopy reveals closed angles. So I performed a laser peripheral iridotomy in the right eye and started him on glaucoma drops, and his pressure improved to 15 very nicely. He has cataracts in both eyes, and he's slightly hyperopic. I performed cataract surgery on the left eye targeting Plano, and after the surgery, I noticed he has a minus 350 refraction. The IOP is better, but it's still high, and the gonioscopy is still shallow. And slit lamp reveals significantly shallow chamber, and you can tell that the IOL is sitting anteriorly. And so we tried cycloplegia. This didn't do anything. In previous cases of aqueous misdirection, I have had some success performing a peripheral laser iridotomy and hyaloidotomy, but I also had cases where after performing the procedure, it caused vitreous prolapse into the anterior chamber, and in one case, vitreous prolapse under the iris, causing almost like a localized iris Bombay configuration, and I had to go back and do a vitrectomy anyway. So I decided to perform an Irido-Zonulo-Hyaloido-Vitrectomy, which has been described in the literature to address severe cases of aqueous misdirection. So I went ahead and did a peritomy and dissected down, and I placed an MBR blade, a 23 gauge, 2.5 millimeters posterior to the limbus. So I'm performing bimanual vitrectomy, and the vitrector port is facing down, and I'm feathering the petal so I create a really nice iridectomy site. But this is only one part of the procedure, and I have to perform the zonulo-hyaloido-vitrectomy. I place the vitrector through the sclerotomy in the pars plana, and with the port up, I'm trying to perform this procedure. And what I'm doing is I'm trying to lift up with the vitrector and push down on the irrigation handpiece to make sure I am able to cause a communication between the anterior posterior chambers. And as I do that, I get a little too aggressive, and you saw I ate the iris a little bit more. And so I'm definitely communicating now, because obviously if I ate the iris, I must be through. But the downside of that is I have a little bit of a bigger iridotomy site because of it. So when I come out, I want to make sure there's no vitreous incarceration to the sclerotomy site. So I actually perform vitrectomy on the sclerotomy to make sure there's no incarceration. I close the sclerotomy and conjunctiva with adoviral suture. And now I want to address this iridectomy site that's a little bit too large. I make a few stab incisions, and I'm going to perform a pupil closure using a 10-0 Prolene suture on a CIF4 needle. I'm able to puncture through the iris on each side, and then use a BSS cannula to place the needle tip through the lumen to help externalize the needle. I use a bond hook to grab the suture that's distal to the iris fixation point. And so I'm using my left McPherson forceps to grab the loop, and you want to grab the loop that's closest to the iris fixation point, and then you make 3 throws with the right McPherson, and then you're going to grab the free suture side with the right McPherson, and I'm pulling on the other side of the suture on the distal side with the left. And as I pull through, this is the Suture sliding knot technique. You saw there was a little clot there that the knot grabbed, so I'm using a Wexel sponge to remove some of that clot. And you want to pull from either side, and as you do that, you're able to see the knot go through. In this case, the visibility is aided by the clot that you see right there. I use a bond hook to grab that distal suture again, the same maneuver, using the left McPherson to grab the loop. Again, I want to hold the loop side that is closest to the iris fixation point. See, I'm switching because I grabbed and pulled on the right there. So now I'm grabbing the loop, and then I'm going to place 1 throw, grab the free end of the suture on this side with the right McPherson, grab the free end on the left side, and then you're able to pull that knot into the anterior chamber. I use intraocular scissors to cut the knot, and then I go ahead and hydrate my incisions. It's difficult to appreciate on this view, but the chamber is much deeper. The IOL is sitting in a more posterior position. Now I'm checking my incisions to make sure they're Seidel negative and there's no evidence for vitreous in the anterior chamber. And anytime I perform a vitrectomy, I like to inject subconjunctival antibiotics. Postoperatively, this patient's pressure improved from 30s down to the teens, and his lens was in better position, the chamber was deeper, and he went from a minus 350 refraction close to Plano, and he was 20/20 uncorrected after surgery. And so now the challenge is, what are we going to do with his other eye? And this other eye is the eye that has a small iridotomy site. But I decided to go ahead and perform cataract surgery and also perform the Irido-Zonulo-Hyaloido-Vitrectomy. I'm making my incisions like typical cataract surgery. I'm injecting intraocular epinephrine. You want to make sure you completely fill the bag with OVD. With these small eyes, the chambers tend to shallow. Go ahead and make a triplanar incision to help with my wound construction. I make a vertical groove, and then I go ahead and make my tunnel and then dive down. I use a puncture technique for my capsulorhexis, and in this case, it went to the left, and I just followed where it wanted to go. Chamber shallowing is a real concern with these small eyes with small anterior chambers. And if there is shallowing of the chamber, you can have a capsulorhexis run out. And as a result, I apply some more viscoelastic as I'm performing my capsulorhexis. Wanted to make sure I didn't come out of the eye. So I went ahead and just injected the viscoelastic while I was doing the rhexis. And you can see it looks much better, and I'm able to go ahead and complete my rhexis without any difficulty. I perform my standard capsular fornix hydrodissection technique, placing the cannula out to the contralateral equator, rotating the bevel down and pushing, and you get a really nice wave. Decompress the bag. I want to sweep to the left while I'm pushing irrigation, sweep to the right, and I'm freeing up the anterior capsulorhexis rim, and as I'm able to do that, the lens spins very nicely. One thing that's difficult to appreciate is that the chamber is extremely shallow during all these maneuvers. I go ahead and place my phaco-tip in the eye, and at this point I feel much more confident. I shouldn't encounter much trouble because I have active irrigation going in the eye. Go ahead and begin my phaco technique, which is a mechanical fracturing technique. I'll double chop where I place the chopper out to the equator in typical horizontal chopping fashion, but then I rotate my hand so that the tip is actually holding the lens from below. I push down with the phaco tip into the lens material. The two instruments meet in the center and fractures the lens. There's no zonular stress with this maneuver. I then perform cross chop, which fractures the contralateral heminucleus into two pieces. Again, all of this is using no ultrasound and no vacuum at all. And this is a mechanical fracturing technique, which is very safe and highly reproducible. After I put the lens in the bag and remove all the viscoelastic, I turn my attention to the vitrectomy portion of the procedure. I perform my conjunctival takedown and peritome. I do a little cautery, and then I place the 23 gauge MVR blade 2.5 millimeters posterior to the limbus. And as I come out, notice the gush of aqueous that comes out through the sclerotomy. And this just confirms that there is aqueous misdirection. So I go ahead and begin vitrectomy, and then I change positions in order to get a better access for my peripheral iridectomy. I go port down, and I go as peripheral as possible, and I feather the pedal in order to get a really nice round peripheral iridectomy. And because of the location of my sclerotomy, I had to switch hands and do the pars plana vitrectomy with my left hand, and I'm holding the irrigation tip with my dominant right hand. And this actually helped me have better control because I'm placing the vitrectomy tip, again, port up so I can visualize the port through the iridectomy site, and I'm pushing down with my dominant hand, which is holding the anterior irrigation port. And so I'm mashing both tips together. And I'm trying to do this with some control, hopefully better than I did the first time. and I'm able to mash the instruments together and create an opening which again breaks through the zonules and breaks through the hyaloid face in order to create communication between the vitreous space and into the anterior chamber. And so you see I'm pulsing very gently with the vitrector. I'm using my irrigation handpiece to kind of push down on the iris so that I pull it away from the cutter. And so I think that that helped minimize me eating the iris again uncontrollably. And so again, you see me pushing and pushing. Again, I'm just trying to mash the two instruments together. And as you can see, I'm mashing when I'm not activating the cutter. And so I'm mashing when I'm not activating the cutter. And then when I'm ready to activate the cutter, I'm pushing down on the iris. I close my sclerotomy and conjunctiva with vertical sutures, hydrate my incisions. The chamber was nice and deep. The lens was in a more posterior position. I like to inject subconjunctival ANSEF after vitrectomy, as I said before. Postoperatively, this patient had pressures in the teens, and his vision was 20/20 uncorrected in both eyes. This was an unusual case of aqueous misdirection that required surgical intervention, and thankfully, an excellent outcome. Thank you for your attention.